Hi, how are you? It's me, Dr. Muhammad Qazafi, and you are watching Dr. Muhammad Qazafi Views. And now I'm going to present a case with the analogy of the case specifically and the topic of traumatic acute subdural hematoma. Assalamu alaikum to everyone and good morning who are listening my video in the morning, and the good evening those people who are listening my video in the evening. First of all, I want to present the 39-year-old male is involved in all, for example, involved in the motor vehicle accident and he was on the motorcycle and he was without helmet, unfortunately, and presented to us in the emergency room with the Glasgow coma scale. On arrival was only 7, the eye was 1, no eye opening on pain stimulation, no verbal response on pain stimulation simultaneously, no motor, only means patient was localizing the pain. So patient is hemodynamically stable and quickly intubated with us. As you know, these kind of the patient, when we are doing the CT scan brain, and we found that there is acute subdural hematoma over the right hemisphere, and that is causing mass effect and compressing of the brain and the midline shift. As you know, this is the topic of the traumatic subarachnoid hemorrhage. I took one analogy from one of my cases, and it is also the traumatic acute subarachnoid hemorrhage. You know, the acute subarachnoid hemorrhage usually occur due to the torn bridging veins at the surface of the brain and damage cortical arteries, and could be produce subdural hematoma. A significant degree of impact is usually required to produce a subdural hematoma. You know how we manage, or how I manage. This patient is comatose and he has a mass lesion seen on the CT scan and significant midline shift associated with more than 5 millimeters. And after ensuring that there is a no life-threatening injury, so this patient should be taken to the operating room for quick decompression via large frontoparieto-temporal craniotomy, or I can convert into the frontotemporoparital big craniectomy. Okay, the indication for surgery here, an acute subdural hematoma with the thickness more than 10 millimeter or midline shift more than 5 millimeter on CT scan, should be surgically evacuated regardless of the patient's GCS score. All patients with an acute subdural hematoma in coma, GCS less than 9, should have an intracranial pressure, and intracranial monitoring is very, very important in these cases. All patients with the Glasgow coma score less than 9 and acute subdural hematoma less than 10 millimeter midline shift, less than 5 millimeter midline shift, and less than 10 millimeter thickness, it undergoes surgical evacuation of the lesion if one of the following thing is present. You know, the GCS score by 2 or more means decrease in the GCS. If right now the GCS is 9, for example, and if it goes down to 7, then definitely the decrease considered in GCS score by 2 or more points. So the asymptomatic, so we have to operate. This is the indication of operation. Asymptomatic or fixed or dilated pupil, definitely also an indication. elevated intracranial pressure more than a 20 millimeter of mercury, it should be the indication. The prognosis is depend on the initial GCS score, the age, and the associated brain damage with subsequent intracranial hypertension. Early surgery may improve the outcome. Whatever the traumatic intracranial hemorrhage can we see, there are the other types of the traumatic intracranial bleeding apart from in the acute subdural hematoma and acute epidural hemorrhage, intraventricular hemorrhage, traumatic subarachnoid hemorrhage are also presenting with that. So the intracerebral contusion, which are of the three subtypes, such as the cope contusion occur at the site of impact, countercope contusion occur at the site remote from the impact due to the movement of the brain inside of the skull, and they are more commonly found in the frontal and temporal pole at the subfrontal area. Gliding contusion occur due to the herniation or tissue tear. Intracerebral hematomas, greater content of the blood compared with the contusion, usually caused by sharing of a small vessel, but should also be caused by the traumatic aneurysm. An intraventricular hemorrhage can cause hydrocephalus requiring cerebrospinal fluid drainage. Subarachnoid hemorrhage does not require surgical evacuation. However, if it is abundant enough, it may cause vasospasm. So the contusion could be small and limited to the cortical layer, but they could also cause significant mass effect. Therefore, contusions have the tendency to increase in size over the first 24 to 48 hours and sometimes over longer. Following a trauma, a prognosis following traumatic contusion will depend on the location, number, and the size of the contusion. Contusion may be a cause of the post-traumatic seizures. Due to their location, they also play a role in cognitive and behavioral deficit following a traumatic brain injury. Patient with mass effect, worsening neurological exam, or refractory high intracranial pressure should undergo surgical evacuation, and patient with a GCS score of 6 or 8 with frontal or temporal contusion more than 20 centimeter with the midline shift, and shift is more than 5 millimeter, or compression of the basal cistern should have surgery. And any contusion with a volume more than 50 centimeters should be evacuated. 50 centimeter cube, should be evacuated. Any lesion of the posterior fossa associated with mass effect or neurological deficits or neurological dysfunction should be evacuated. Some other indication for anti-epileptic medication here, such as the prophylaxis of the post-traumatic seizure, is not recommended, but the prophylaxis of the early post-traumatic seizure within 7 days is recommended, but has not been shown to change the overall outcome. I want to little extend the lecture because I gave you some principal points on the according to my case, which I kept for the analogy for presenting this case. Now I want to give you some more details which I think it must be discussed among us. Actually, the acute subdural hematoma has been a major part of traumatic brain injury, and it is a common clinical entity for the neurosurgeons and usually results in poor prognosis. Acute subdural hematoma is easily diagnosed on brain computerized tomography on extraaxial hyperdense crescent mass between the dura and the brain parenchyma. Intracranial hypertension may be followed by the acute space occupying hematoma and the brain edema because of the accompanying brain damage. The hematoma usually arise from relatively low pressure venous bleeding due to the damaged venous veins, which may be traumatic or sometimes spontaneous, but we are considering here traumatic. Arterial etiology may contribute a small contribution or a small portion, but high incidence of the cortical artery rupture has been reported. Acute subdural hematoma occur frequently under acceleration deceleration conditions and resulting from there the linear brain acceleration within the skull, causing the stretch injuries to veins and arteries. So the acute subdural hematoma is often complicated by diffuse axonal injury, global and focal ischemia, reactive hyperemia, and delayed hematoma expansion. Ischemic brain damage adversely affect outcome and morbidity. The reduced ischemic brain damage. To reduce the ischemic brain damage, the early reduction of the brain shift as well as control of increased intracranial pressure must be mandatory. Regardless of the complicated pathophysiology of acute subdural hematoma, the extent of the primary brain injury underlying the acute subdural hematoma is the most important factor affecting outcome. The pathophysiology of acute subdural hematoma varies with age, and that currently employed resuscitation and treatment method have differently improved the outcome of the younger patient. And a large cohort study of the traumatic acute subdural hematoma demonstrated a lower mortality rate than those of previous report. Earlier diagnosis with the CT scan imaging and the treatment improvement from the regionalization of care in center of excellence may affect the lower mortality. Acute subdural hematoma is the most common diagnosis in the elderly over 65 years in the nationwide data bank. It is a higher chance of taking antiplatelets, anticoagulants, and having a medical illness and brain atrophy in the old age. It could make a neurosurgeon in agony to decide the critical care of traumatic acute subdural hematoma. We review the critical care and the surgical management for the traumatic acute subdural hematoma and discuss the pre-operative consideration in the various situations and the optimal way to get the best outcome. Regarding the pathophysiology, I must want to discuss, because as we understand this pathophysiology, we can understand more acute subdural hematoma. Acute subdural hematoma lead to the accumulation of the fresh hematoma on subdural space and complex variable intracranial condition as intracranial pressure, edema, cerebral blood flow change, parenchyma contusion, or direct injuries can affect all. In early stage of the acute subdural hematoma, cerebral blood flow decrease occurred markedly. However, the blood pressure and the arterial oxygen were non-pathological condition in early acute subdural hematoma stage. Ongoing intracranial pressure increase lead to the cerebral perfusion pressure, decrease in cerebral cerebral blood flow, decrease occurred by the cerebral perfusion pressure, decrease in additionally the disruption of the cerebral autoregulation, vasospasm, decrease of metabolic demand may lead to cerebral blood flow decreasing. So it is a mechanism, it is a cascade mechanism, one after other it happening. ongoing intracranial pressure definitely increase the cerebral perfusion pressure decrease. And then cerebral perfusion pressure decrease, it may decrease the cerebral blood flow. And as cerebral blood flow decrease, definitely cerebral perfusion pressure is decreased. So in additionally the disruption of the cerebral autoregulation mechanism, then definitely the vasospasm and the decreasing of the metabolic demand may lead to the decreasing cerebral blood flow. Acute subdural hematoma may occur systemic coagulopathy because the brain injury stimulus or stimulate coagulation pathway and lead to the systemic bleeding tendency. So the systemic coagulopathy after acute subdural hematoma may occur hemostasis changes, hematoma expansion, intracranial hematoma, and lead to the poor outcome. Here I want to take the D dimer level associated with outcome in patient with head trauma. However, D dimer level don't reflect patient outcome perfectly. Delayed deterioration occur in elderly patient who got acute subdural hematoma frequently. Elderly patient got atrophic brain volume and more large subdural space. Extra subdural space may compensate increasing of hematoma and brain swelling before neurological deterioration. Delayed deterioration may occur often within 24 hours after trauma, and it caused by trauma expansion. Traumatic delayed intracerebral hematoma, increased cerebral contusion hematoma, and edema. So recently many of the elderly patients took antiplatelet agent or anticoagulation due to the cardiovascular or cerebrovascular disease. So these are the reasons. Neurosurgeons should define that the antiplatelet agent or anticoagulant is a new risk factor for delaying deterioration in elderly patient with head trauma, despite elderly patient shows normal CT scan initially. Acute subdural hematoma may detect with the delayed deterioration from 9 hours to 3 days after trauma, and the elderly patient who got head traumatic should be observed closely and be taken serial CT scans. Here the major part, definitely I presented some surgical intervention indication of my patient just before in front of you for the analogy, but I want to put some light over the general management of the acute subdural hematoma, which is the critical care of the acute subdural hematoma. So the management of the increased intracranial pressure is the key element for the head trauma, and the situation with increased intracranial pressure happen frequently with acute subdural hematoma. Increased ICP over 22 mmHg may lead to the poor outcome of traumatic brain injury. Thus, various protocols for intracranial pressure lowering were introduced in neurotrauma field. Head elevation of 30 degrees with cervical collar loosening can improve venous return and help to decrease intracranial pressure. Hyperventilation can decrease intracranial pressure by inducing vasoconstriction. However, respiratory alkalosis may lead to exacerbate secondary ischemia. Few patients who got traumatic brain injury with hyperventilation, partial pressure of carbon dioxide 25 mmHg for 5 days. In this randomized trial, the hyperventilation group had a worse outcome than non-hyperventilation group. So here the people are thinking the hyperventilation always a solution. Actually it's not. We have to take care for that, because the partial pressure of the carbon dioxide of 30 mmHg is the best target of the hyperventilation rather than less. Guidelines recommend the hyperventilation as a temporary measure for reduction of elevation of intracranial pressure. The hypertonic or hyperosmolar fluid therapy can occur osmotic gradient and lead to fluid shifting from brain intracellular space to circulation system. However, it can use only temporary until surgical treatment is not provided or not been engaged. So the administration of the intravenous steroid has no benefit evidence for the acute subdural hematoma patient. Use of the steroid sometimes harmful effect, causing harmful effect for the acute subdural hematoma patient in larger scale, and prospective randomized multiple study trial suggestive for that. Hypothermia is a challenging for the treatment of acute subdural hematoma patient. Mild therapeutic hypothermia after cardiac arrest and myocardial infarction showed improving patient survival rate and increasing favorable neurological outcome. However, hypothermia for a traumatic brain injury does not establish their definitive availability and the benefits. Hypothermia have been known to reperfusion injury at some extent. However, result of the hypothermia for the traumatic brain injury shows different aspect in clinical fields. The therapeutic hypothermia plus standard care to reduce ICP did not result in outcome better than those with standard care alone in patient with intracranial pressure of more than 20 mmHg after traumatic brain injury. In Brain Trauma Foundation traumatic brain injury guidelines, the hypothermal treatment of traumatic brain injury patient tends to non-improving outcome when was used earlier. So within 2.5 hours after the trauma or short-term 48 hours and prophylactic, it is okay and it is workable. But the majority of these not identify the improvement with the use of hypothermia. Although there were a few patients that may have benefited from hypothermia, otherwise the recommended empiric hypothermia should be avoided, and hypothermia may use in very limiting condition for keeping body temperature control at their focus with intent to avoid hyperthermia. Mild hypothermia may try to be applied in traumatic brain patient who may get some benefit, but not much. Here I want to put some light over the seizure control use of the antiepileptic drugs for the acute subdural hematoma patients have controversy. 25% of acute subdural hematoma patients experience seizures attack, and the seizures can occur increasing intracranial pressure or increasing brain metabolic demand as this is a reason, but definitely only 25% when they are getting that, so should we give to the 100% people phenytoin? But yes, because it is there the controversy, we cannot say no or we cannot say big yes, but we can say that the use of the phenytoin reduced seizure incidence from 14 to 4%, and phenytoin with the phosphonamide phenytoin is commonly used because it can administered by intravenous line and can be changed in tablet easily, so it is not causing deep sedation. And recently the levetiracetam arrived at a first choice of the anti-epileptic drug with equivalent efficacy, and the levetiracetam demonstrate equal effectiveness compared with the phenytoin or seizures prevention after traumatic brain injury. Valproate may affect psychiatric or behavioral problem, but phenytoin and then levetiracetam has a better role in that view. Usage of the anti-epileptic drug after traumatic brain injury may reduce early stage seizure. However, late stage of seizure cannot be prevented. So if traumatic brain injury have not seizure during a week or a month after traumatic brain injury, so prophylactic anti-epileptic drug can be stopped safely. Anticoagulants, antiplatelet agent, use of anticoagulant or antiplatelet agent is increasing due to the lifelong medical disease condition in aging population. Using of anticoagulants or antiplatelet agent have a risk as a coagulopathy or increasing bleeding tendency. Hematoma expansion is well recognized risk factor of life-threatening in acute subdural hematoma, and coagulopathy is one of the most important risk factors for acute subdural hematoma expansion. Patients who take oral anticoagulants have 4 to 15-fold increased subdural hematoma risk and may expand hematoma easily and increase risk of death, have worse outcome. Appropriate reversal of the coagulopathy is essential medical management to improve acute subdural hematoma. Warfarin, such as the vitamin K antagonist, is typical anticoagulation agent, and patients who take warfarin should take 10 mg vitamin K bolus with 4-factor prothrombin complex concentrate 25 to 50 micro per gram, depend on the international normalized ratio. Recombinant factor 7A and fresh frozen plasma is useful antidote for the warfarin in emergent acute subdural hematoma situation. Recent use of the non-vitamin K antagonist oral anticoagulant is increasing due to the difficulty of warfarin monitoring. However, such kind of non-vitamin K antagonist oral anticoagulant such as the dabigatran, apixaban, edoxaban, and rivaroxaban haven't antidote for the reversal of the coagulopathy. Even though, according to the United States Food and Drug Administration, approved idurocizumab and the adanstant alpha for non-vitamin K antagonist oral anticoagulant antidote. So it need to be more investigation for effectiveness. If traumatic brain injury patient who take anticoagulation agent does not need surgical treatment immediately, should discontinue anticoagulation agent as soon as possible, use effective antidote, and keep close observation for immediate. Surgeon should recognize of coagulopathy during surgery and risk factor. Acute subdural hematoma patient who take antiplatelet agent should continue antiplatelet medicine quickly, because the antiplatelet agent has no antidote and reversal of coagulopathy takes several days. So the platelet transfusion has been considered for several of the platelet function recover. However, resumption of the anticoagulation and antiplatelet agent after acute subdural hematoma surgery is not clearly defined. Generally, it may resume after 3 to 7 days after the surgery, and the resumption time is depend on each patient medical risk. Tranexamic acid for the acute subdural hematoma is a synthetic material made by the lysine amino acid, which affect antifibrinolytic role by binding to the plasminogen and the preventing plasminogen fibrin interaction and clot dissolution. And this tranexamic acid is used to reduce bleeding in trauma and off-label use widely. So according to the tranexamic acid, it may increase the possibility of thromboembolic complication. However, clinical trials reported no increase in the thromboembolic incidence. but people are using that, and definitely I just want to mention in your knowledge that if the people are using that, you should know that what are the effect of this, or what could be the effect of this. Early treatment was more effective than the later treatment in patients with mild to moderate head injury when you are using tranexamic acid. The risk of the vascular occlusion event was similar in both groups, and the people are using tranexamic acid or those are not using tranexamic acid. So in that regard, it is too much debatable and important topic, but definitely we should know that it is the effect of this. Expanding subdural hematoma at a subacute stage sometime. The subdural hematoma is chronologically defined as a hematoma that evolves from the acute subdural hematoma within 4 to 21 days of the head injury, and the problematic subacute subdural hematoma is a rare complication in the usual course of acute subdural hematoma. The clinical significance of subacute and subdural hematoma result from expanding the hematoma and making the intracranial hypertension. This expanding subacute subdural hematoma can be defined an initially non-operated acute subdural hematoma that shows rapid neurological deterioration and expansion of the hematoma volume in the subacute state. The exact mechanism of expanding subacute subdural hematoma is still not elucidated, but several factors such as the old age, bleeding tendency, thicker initial hematoma, lower blood hemoglobin levels, and higher blood leukocyte count may be involved. And the subacute subdural hematoma may be a different disease entity from chronic subdural hematoma, and cerebrospinal fluid may take a role in the increase in the mass effect. Expanding subacute subdural hematoma have been reported to occur in approximately 10 to 30% of acute subdural hematoma treated conservatively. And clinical deterioration usually happens rapidly. The clinical concern and surgical intervention of expanding subacute subdural hematoma usually occur around 13 days after head trauma, and the various surgical methods were proposed for the subacute subdural hematoma, including craniotomy, craniectomy, and the burr hole procedure. It could be said that the aim of the surgery is rapid and safe recovery from the symptoms. From the point of this view, the minimal surgery could be considered is important thing. Reported that the only one case in 23 cases of expanding a subacute subdural hematoma was treated with craniotomy, and the other were with the burr hole or the twist drill craniotomy with closed drainage, and no revision surgery was required. So this is also a fact we have to consider. Expanding subacute subdural hematoma is worthwhile to keep in mind is a pitfall in non-surgical management of acute subdural hematoma. So the brain CT around the 13 days after the head trauma of the acute subdural hematoma should be taken, and the older patient with relatively large acute subdural hematoma should be carefully monitored. However, an expanding subacute subdural hematoma. Surgical management of acute subdural hematoma, I want to mention, I already mentioned, but I want to put some light over it like that. The decompressive cranial surgery has a long history, and we can find legacy of the neurosurgery from archaeological evidence. This surgical procedure have been very useful procedure in traumatic brain injury. Decompressive craniotomy can reduce patient death rate. However, it does not mean that the decompression can be helped to good functional outcome always. Acute subdural hematoma is a space-occupying lesion and may accompany a brain edema, so the character of acute subdural hematoma may lead to chain reaction with brain herniation and secondary brain injury. So the indication for decompressive surgery may be severe mass effect of traumatic brain. Because the purpose of the decompressive surgery is preventive of brain herniation and secondary brain injury, so the surgical decision could consider that the CT scan Glasgow Coma Scale score is important, and neurological deterioration, intracranial and increased intracranial pressure sign also being considered. Surgical decision was associated with the timing of the surgery. The timing of the surgery may be an important role to save an injured brain tissue from secondary ischemia due to the increased intracranial pressure. However, it is very difficult to study that the fine relationship between the timing of surgery and outcome, because the severe injured patient may undergo surgery more earlier period. In fact, many of the study failed demonstrated. However, the decompressive craniectomy or the craniotomy is a preferred treatment option. However, whether decompressive craniectomy or craniotomy is suitable procedure for the acute subdural hematoma have controversial point of view on different people. Several people are thinking that there is a decompressive craniectomy which have brain parenchyma injury or swelling, and the craniotomy for acute subdural hematoma may be the alternative procedure for the acute subdural hematoma without brain parenchyma injury or swelling, because the decompressive craniectomy have their own complication risk factor of additional cranioplasty surgery after that. So, comparing procedure outcome of decompressive craniectomy and the craniotomy in acute subdural hematoma patient, so it is very important. Poor outcome was higher, about 60% versus 50% in the craniotomy group. So there is a different groups did the different kind of studies, and they found different kind of results accordingly. But both options are open, and we have to choose to seeing after the current condition of the patient. As you know, there are the endoscopic surgery for the acute subdural hematoma, and decompressive craniectomy is open required to the patient for the acute subdural hematoma with brain edema. However, craniotomy is a less invasive alternate that may avoid the complication and the later cranioplasty associated with the decompressive craniectomy in certain situations. If the craniotomy is a sufficient management for the acute subdural hematoma, endoscopic surgery through a small craniotomy will be an alternate to the conventional large craniotomy to evacuate the hematoma, and the endoscopic surgery can save time and reduce blood loss from the large craniotomy. So in the subdural pathology, endoscopic approach have been used to treat the empyema and the chronic hematoma, and endoscopic removal of acute subdural hematoma have been reported recently, but not well-designed comprehensive study which we can say it is the best or it is only an option. Although endoscopic surgery for the acute subdural hematoma could be performed in a very selected patient, and it will be more implemented in the future. Possible candidate for the endoscopic procedure such as the acute subdural hematoma, it definitely the choice of the patient, it should be very certain and appropriate. Outcome of acute subdural hematoma have been dismal because of its combination of diffuse axonal injury and accompanying intracranial hypertension. When the surgical treatment is required, large craniotomy and or craniectomy is inevitable, but the incidence rate in the elderly increased, and the different management policies are emerging and welcomed very well all over the groups of the neurosurgeons. Antiplatelet and anticoagulant become a bigger issue not to expand the hematoma, and is preparing the hematoma evacuation surgery, and minimal invasive surgery include the burr hole surgery and the endoscopic surgery may be a good option to evacuate the acute subdural hematoma. The management plan for the acute subdural hematoma should be individualized based on the age, neurological status, radiological finding, and the patient's medical condition. So I want to conclude my lecture here. I think definitely the thirst of the knowledge cannot be completed, but I presented myself in front of you as regard the acute subdural hematoma outcome management and the evaluation. I hope you will like it. If you like it, please share it and subscribe me. Thank you so much. I will continue these lectures till I can.